Hi, Raju.
Hi, Michael. So you must be just past the winter school, and it's unique that we are meeting just one day after Word Day. And what is the article that you have pulled out today?
I came up on an article which is important for juvenile idiopathic arthritis. It's on a potentially very severe complication that is uveitis. As you know, we start with eye drops with steroids, which are decreased. And then, if we have one or two drops per day for 3 months, then we need to have a systemic treatment. First, we treat with methotrexate, and then, if necessary, we go on TNF blocker. And usually, we use adalimumab since we have studies showing the efficacy in JIA uveitis. And the problem, what we have is that adalimumab is much shorter in the way to have an effect than methotrexate, and so it's easier to do steroid weaning.
True.
So I would prefer to start really with adalimumab if it would be possible.
True, Michael, I agree with you. But adalimumab in resource challenged countries is a costly option, especially because it may go on for a long period of time. In some countries, it may not be available. And what we often do is that if methotrexate is not working, we add or substitute with mycophenolate mofetil before going to TNF blockade.
Okay, Raju. Now let's go back to adalimumab. And when the disease is calm, then the clinician has a challenge because patients often want to stop the treatment as early as possible, especially because they have absolutely no symptoms. So to accept for a child to have an injection every 2 weeks is difficult. And the problem is that the current recommendation says 2 years without any ocular inflammation.
True. And that seems like a reasonable recommendation. But I'm sure that there would be a high relapse rate and a shorter time to recurrence of uveitis after stopping immunosuppressive therapies. And I don't think that there is any randomized trial that has evaluated the risks and benefits of stopping versus continuing a diet.
Yes, and this is why this adjust study is important and give us some more information. It is a randomized controlled trial where in patient calm for the uveitis, they stopped ADA to give placebo or they continued with adalimumab. And they found that the relapse rate was significantly higher in the placebo arm, and it was more likely in patients below 12 years of age to have flare of uveitis. And then after flare, they all restarted adalimumab and again had a control of inflammation.
And Michael, can you tell me the difference about visual acuity or safety in both groups?
There were no difference between both groups. So really, the difference they have seen is only on the activity of disease. And this is important because we always are very scared to stop adalimumab because if you have a flare and then you have some more problems with visual acuity, this is not good for the patient. And when given as a monotherapy, the patient more often develop anti-adalimumab antibodies. And it was increased in the placebo group. And this is what we fear when we stop adalimumab is to let these antibodies coping, but they were not blocking since the control of inflammation was obtained when we reintroduced adalimumab. So probably some of these antibodies are not active against the treatment.
Yeah, maybe perhaps continuing methotrexate alongside may prevent the development of these antibodies, like in DADA 2, where patients who receive etanercept, they would also receive methotrexate to prevent this. But this is a different story. What was the sample size? Was that a limitation of the study? And what did you finally learn, Michael?
So, right, the sample size was one of the major limitations of the study. But I think still it's giving us interesting information. So we know that it's that from our clinics that relapses after withdrawal of adalimumab are frequent. And here we see that it's confirmed. And so this will also help us to continue adalimumab at least for 2 years with inactive disease to get a close control of A inflammation. And what is also important is that a relapse does not seem to be a big challenge for ocular damage. And this is also reassuring, showing us that we need to try to stop adalimumab when it is possible after 2 years, and then retreat very quickly. But then we are also, and this is an important message also of the paper, we need to control very closely patient when we stop adalimumab to catch when there is a new flare. So thank you very much, Raju, for this discussion.
Thank you, Michael. But I would tell you that in our country, if a parent has to buy adalimumab for 2 years, he would perhaps have to rob a bank.
Mm.
But so be it. Thank you for this enlightening discussion.